data that we have as of now, the updated data, that is probably is in 2019 October. So the prevalence according to that data is approximately 11.8%. And if you really want to divide this prevalence, then it comes to, there is some difference between the urban and the rural areas. So if you look at the urban areas, it's approximately 10.9 to 14.2%. However, in rural areas, it is approximately 3% to 7.8%. So we have a big population with a quite good prevalence to serve, to take care of their eyes, and each and every one actually require a eye checkup, because everybody has a risk for diabetic retinal complications. Predominantly what we see in our clinics, it is diabetic retinopathy. So diabetic retinopathy is, it's quite a wide range. So we see patients from mild diabetic retinopathy till, severe diabetic retinopathy, with a lot of other, additions in diabetic retinopathy, for example, diabetic macular edema. So diabetic macular edema is the one which is concerning us. It's because a lot of patients nowadays, a lot of young population that we are seeing is they do not have many diabetic retinopathy severe changes, but they have diabetic macular edema. And diabetic macular edema is kind of, swelling right in the center of the retina. Center of the retina is the one which is required for your functioning, day-to-day functioning. So that is the one which brings a patient towards you with, with that they need attention because they are not able to function. So that is very important nowadays in young population, obviously in old population also, but the population which is a bread and butter, for the family, if that happens, then it's concerning. Some other complications, for example, that we see is diabetes related, some of the nerves which gets paralyzed, paralyzed, and patients see double vision. And especially if I were to name one nerve which is most commonly involved is the sixth nerve palsy. That's what we say. And other complications are like early cataract formations. These all diabetic patients, they tend to have cataract formation at much earlier comparison to your normal age-related progression of cataract. So these are the predominant complications, visual complications that we see with diabetic patients. If I need to share only my experience, because I, being a retina specialist, I run retina clinics alone. So predominantly 50 and more than 50% of patients in my clinic, they are diabetic retinopathy patients at various stages. So it means that gives you a whole idea that what kind of prevalence and what kind of patient population, which is being affected with diabetic retinopathy that we are dealing with. Means 50% and more are diabetic retinopathy cases, and rest other diabetic, retinal complications, they fall into the rest of the 50%. So quite huge number. It's a very important question, very, very important question. And I think organizations like, your initiative of DR Barometer, that would help us to spread this awareness. And organizations, and I would like to thank IFA, IAPB, these kind of organizations should really help all ophthalmologists and retina specialists to really clear this misconception. Misconception is patients, they feel that until I see fine, my eyes are fine, which is not the case. Each and every diabetic should get the screening done, even if he sees fine, because diabetic retinopathy is a disease which starts from the periphery of the retina, and it doesn't give you any kind of sign in the beginning. And by the time you start complaining, and by the time you have some kind of visual symptoms, disease is pretty late. So you do not want that, because it is difficult not only for you, but even when you come to us with such kind of disease pattern, it's difficult for us to bring the vision, whatever you have lost sometimes. So the misconception is, if I'm seeing fine, my eyes are fine, rule it out. Always get a screening done by a retina specialist and see whether there are any early signs of diabetic retinopathy, because if there are any early signs of diabetic retinopathy, they can be treated without any further complications and losing vision. Okay, so get the screening done even if you are seeing fine. If you look at the Western countries like US or many other Western countries, I was part of US system at one point of time. So what happens there, even at the primary contact, if a patient visits a diabetic clinic, usually they have a screening tool there itself. So they take fundus images, and if some images, they find, there are some changes of diabetic retinopathy, then the patient is being referred to a retina specialist or an eye clinic, which is not the case in India. India differs in this way because we are not very much equipped with fundus cameras at the primary contact at diabetologist clinics. So hardly very few clinics in the metro cities, means I would say in the largest cities, are the ones which are doing it at their doorstep where there is primary contact with the diabetologist. But most of the time, no. Most of the time, what happens, the way it works is a diabetic patient goes to a physician's clinic, and then it depends on how crowded the physician is and how busy is he. Then sometimes they are being referred just by a word of mouth, and some of the diabetologists, they write me a letter that I need an eye examination of this person because he's been having diabetes, uncontrolled diabetes, since quite long. So it's not the streamlined way to do the things. So checkups are not frequent here. So that is the challenge that we have. India is a big country. We are divided into states, the similar way US is, and health is a state subject. So it differs. For example, the state from where I belong, there is a government system, and a lot of patients who have certain income, they are under below certain income, they are given a card. So with that card, they can have access to healthcare, and government funds it. But that doesn't happen across India. So means there is variability. So you cannot say that, for example, in UK, you have NHS everywhere. But here you do not have that system. Each and every government is independent. So somewhere it is okay and somewhere it's variable. And most of the time, patients, they pay out of their pocket because insurance is still not in. So means it's quite variable. We all belong to a scientific fraternity in retina, and as far as treatment is concerned, we follow the standard guidelines, all the guidelines which have come through to us through level 1 evidences. So we follow standard guidelines which entire world follows. The only difference comes in as a clinician. Sometimes, because of the geographic differences and the country specific differences and patient-centric differences, I need to modify the treatment because I need to check that what is the financial background of that patient, and how is he going to follow. And so sometimes our decisions, they differ. That's where we call it as a clinician's discretion. So this is not the, I would say, this happens everywhere. This is not just India. Everywhere, even US and every country, it becomes more of clinicians driven rather than just the standard guidelines. But if you specifically ask about the guidelines of treatment, we do follow, which the entire world follows. first and last, my answer in India is financial constraints. And the reason is obvious, because we as a nation still are very much underinsured. So, and this diabetic treatment, as of now, the primary treatment modality is monoclonal antibodies, biologics, and biologics, they cost a lot. So thanks to some of the molecules, biosimilars, which are coming in, and probably, we are hoping that India is a country which is the leader in biosimilars, and probably that is the one which is going to make this therapy cheaper. And then most, probably in future, many people might have access to it because they can afford it. As of now, the challenge is patients, they continue 2 injections, 3 injections, 4 injections, and they are tired at the end of 6 injections most of the time, 3 to 6 injections. In contrast, if you look at US, if you look at any other developed world, means I was in US system, so I have seen 40, 50, even 100 injections, because they are quite well covered with insurance. So challenges, financial constraints are there. So it is very difficult for us to really give them adequate therapy for a long time. That's where I, told you in the last question also that it depends on how, what kind of finances that patient has and how frequently I should treat him. So these are the challenges. Yeah, absolutely. In last couple of years, if you see, diabetic retinopathy was our last priority, to be frank, because the reason behind is diabetic patients, they were not willing to come, because everywhere people knew that, any patient who has comorbidity, they have more chance of morbidity and death. So people, they were not quite of keen to visit hospital. And on the other aspect, diabetic related vision complication, they do not progress immediately. It's a kind of a slow progress. So still we could, delay the visits in diabetic related retinopathy related cases, but we had priority for other diseases. For example, macular degeneration. Macular degeneration patients, they cannot wait. So we have put all these diabetic retinopathy patients to the highest interval, whatever we could, maximum interval that whatever we could. So, but although, that was a need, but over the time after 2 years, when we realized, means it didn't turn out well, because we started seeing really bad diabetic complications later. But that was required at that time. But now, since last 6 months, we are back. We are back to the routine intervals, although in between there are a lot of tough cases, difficult, challenging cases that we had because of, delay in the treatment. But now we are back since last 6 months. I'm not sure, with this new Omicron, how things are going to go. If you see on the side of medicine, ophthalmology is kind of a different field, and even in ophthalmology, if you talk about retina, it's even different. The reason behind is retina, I need to see retina, per se. I cannot just have a, visual or a Zoom consultation. So if I need to examine retina, I need to dilate that patient. I need to examine and have a look into the retina. So, it was not a practical solution, although what we were doing was we were trying to have a phone call to all our patients whom we thought, they were kind of critical and they needed treatment at that point of time. So their follow-up, we were just trying to see whether, overall vision is fine. There is no bleeding inside the eye, sudden bleeding, patient's sudden vision drop, all those things we were tracking. But that was not really realistic. That was a reason that we later found that, all those patients whom we missed, they came with a lot of complications and difficult to manage. So engagement wise, digital engagement was not real successful as far as retina is concerned. It was successful in other fields probably. So we had, telecommunications, but ultimately we had to see patients. means we call them back since last 6 months whenever whosoever was left in examination. For the time means what we are seeing in India per se, previously means now it is my 10th or 12th year of practice. In this one decade, what change I have seen and witnessed in India is 10 years before, people were not talking about diabetic eye-related complications. Now I go to social gatherings. Now there is a talk. Somebody or else in their family had some kind of eye complication because of diabetes. So there is an overall awareness is building up because probably, they talk to their friends and peer groups. So then they come, and so even physicians are more aware. So we get more and more referrals from physicians, but still it has to improve. And I definitely request organizations like you to help us improve this, specifically like, region-wise, country-wise, where screening is not really in a streamlined manner. Very good question. What happened, patients' priority changed. They changed their priority, their finances changed. So people have, they wanted to go for their cardiac checkup first. They told, we want to get our cardiac checkup done, and we want to get our, we have somebody had stroke or something. So their priorities changed. Again, coming back to the square one, that my vision is okay as of now. It is not too bad. I can wait. So, but I have some other troubles which I need to take care. My finances are not great. I cannot have injections again till I have serious trouble. So means we were trying to call them, and people were willing, and that means the part where I practice, is beautiful. People are wonderful here, and means they speak their heart. That is what thing that I like. So if they really are in trouble, they would tell you on face, doctor, means I have this trouble, I am not able to come, I have this thing to focus upon. So in these pandemic times, we realize people have different priorities compared to the eye. So I was definitely ignored. So major means it's a one-liner, fear of COVID. That's what we saw in last couple of years. Means I had so many older population, means 70, 80 years old patients. They always kept calling, saying, doctor, I'm really worried if I come, whether I should come in the morning or shall I come in the evening? What time you have less crowd? I do not want to be a part of too much of crowd. I have diabetes. I have one stent done. I have cardiac issues. And I have heard that, these are the comorbidities which are not really good if I get COVID. They were coming with gloves. They were coming all protected, all these old people. So means that was the kind of fear of COVID was really gripping the older population. What I think, not only us, I think across the country, what we did was we all have shifted the patients who had comorbidities on a different time slot. We were telling them, you come probably after 3 o'clock in the afternoon, and you will be seated in a different area where you will not have, interaction with many people. So it means that social distancing is very well maintained. And there is a rapid exit path in case your vision and everything on a primary checkup is okay. And so means trying to give them confidence so that, we treat them at early stage. So otherwise, what we were doing was we were trying to check their previous records, that how bad their edemas were, how bad their diabetic retinopathy was. So I think this was a kind of a novel strategy that we could adopt, and that was quite successful. So we could filter out patients, and all these older patients, when we reviewed their records, then any patient whom we could find as a clinician that, okay, I'm okay for this patient not to come to the clinic. So that stratification was great. And that turned out that even at the later stage, when we saw those patients, they were quite stable. So reviewing the older records, and based on that, rather than fixed intervals, based on that, we could delay their management. So that kind of management strategy really worked out, apart from the quick and early and exit pathway and social distancing when they come in. Very important. So what I feel is, specifically again, because it's in India spotlight, what I would say is, at every point of contact, because India is a big country, we have different kind of people to provide care to all the diabetics. A rural person, he goes to a local physician, sometimes probably even a quack, okay, and somebody from an urban area, he would go to an optometrist, not even a doctor. Somebody would go to a general ophthalmologist. Somebody would go to so the primary contact is most of the time a physician or an optometrist, not the retina specialist. So we have the least importance here. So if you really want to educate people, our efforts should be at the physician's clinic. So rather than us, an optometrist should be educated, and a physician should be educated. Wherever a patient is going for a regular checkup, there has to be signboards or education material which says that yes, even if your vision is fine, you definitely need to get screened for your eyes. So that's what I feel. So I'm quite frank in my opinion here. We have been trying kind of fruitless strategies since last decade. So what has been happening is, probably the way we are trying to screen diabetic population in this country, by organizing camps, by going and doing a mass screening, and then trying to pick up some of the diabetic retinopathy cases, has not worked. So because the follow-up is poor, these patients, they never turn up. So what, as me and myself and my group, we have been trying to adopt few different strategies which we think that could work over the time. And one of the strategy could be a global strategy. What we are trying to bring is, first, I'll tell you in the past what we did. As I told you in the beginning, that why the screening is less, because we are not equipped with fundus cameras. We are not equipped with fundus cameras everywhere. And the simple reason was that people won't afford it. Nobody would buy a 5 lakhs, or means in Indian currency, or 6 lakh rupees investment for just a screening in their clinic. So I designed the device, smartphone-based device, 5 years before, and which is called MI RetCam. It's a smartphone-based imaging device, which is now present in 47 countries for various purposes. The primary purpose was to provide this cost-effective instrument, which cost just 20,000 rupees, to different areas, so that people have access to the instrument for screening. But still, this instrument should be utilized by at least a technician or somebody to use it. So what now we are doing in the process is, I seriously feel that if you want a patient engagement and trying to take care of diabetic retinopathy, you have to bring this care at home. You have to bring this screening at home. That is the only realistic solution, I feel, going forward, where you can save people from blindness. And that can happen. We are trying to design a glass which is called RIGS, retinal imaging glasses by Sharma. So what envision is that these patients are prescribed these glasses. This glass is like a camera. It has all the mechanism of camera. And this patient is instructed to wear this glass once in 3 months, or in the beginning. And then this has an artificial intelligence in it. And once this artificial intelligence works on your phone, then it automatically, gives you a message that you need a retina specialist checkup, or you can wait for 6 months or a year. You remember, means I think you would agree, your parents. There was a time when your parents and my parents were going for even blood pressure and blood sugar checkup to a clinic, right? But now what happens? Now they check their blood sugars at home. Now they check their blood pressures at home. And even sometimes the insulin dose is modified based on their sugar levels at home. So that is what is going to solve this diabetic retinopathy blindness problem once we bring this retinopathy screening at home. So that is what we are trying to bring. It's challenging, it's difficult. We have been trying since 3 years, but still, there are a lot of challenges in this. So this was one aspect. Another aspect which we are trying is, in India-centric, this is not global-centric. RIGS is a global-centric solution, but another India-centric solution, I will tell you, what are the problems that we identified in India is patient is unaware, awareness is poor. Second is, sometimes, diabetologist, I cannot blame the diabetologist, he doesn't refer. He doesn't say to a patient that, you go and get an eye checkup. He's crowded, means he has a lot of patients to see. He cannot write letter to each and every patient that you go and get an eye examination done. So that is a problem. And third is, sometimes some diabetologists and some physicians, they do that. They try to they make an effort and they try to tell patients, okay, you go for an eye checkup. But what we see in practice is sometimes these patients, they end up into an optometry clinic or in a general eye clinic where they are not even dilated and retina is not examined. They just come back with the glasses. So there is a disconnect between physician and a right place to get the checkup done. So we are trying to bring an application which is called Diabetic Blindness Free India. Right now, it is in the process of the ground testing, but hopefully within few months, you should be seeing up on App Store and the Play Store. So where we would be connecting physicians and the diabetologists together, and hopefully the challenges, what I described you, and I told you before, 3 challenges, probably, we could address that. So that is what I envision, and I think that is the engagement and solution that could help this country. Key message is very simple, means all the diabetics, means they should understand that diabetes is not a difficult disease. Diabetics can live a happy life and a long life as good as a normal patient. It's a very forgiving disease, very slow disease. But if you really want diabetes to forgive you, you should not forget diabetes. You should not forget the time for regular checkups. You should not forget time for regular screening. You should not forget your regular monitoring of blood sugars. So it's a forgiving disease until unless you don't forget it.